you for joining us. My name is Caine Young. I am the brand ambassador for VNAO. For those who are not able to join us this morning or will be joining us late, we are recording the whole seminar so that you'll be able to see everything from beginning to end. It's my pleasure to introduce to you Erika Caine, who is going to be leading the discussion today on everything hospice. Erika, take this moment to introduce yourself.
Hi, everyone. My name is Erika Caine. I'm a nurse practitioner and currently our hospice director for the VNAO. So I started with hospice about a year ago. And before that, I've been working in internal medicine, hematology, and oncology as a nurse practitioner. And prior to that, I was an ICU float nurse at UH Main campus for 3 years. So my background is pretty vast and generally medicine. So I've got to see all avenues, but I found that I was really gravitated towards those who were critically ill and those who were going to be actively dying. So there comes a fine line with those who have chronic conditions and terminal diagnoses and bridging them to the end result of actively dying. It is a process that all of us go through at some point. So there is a portion that we like to go through that's comforting to the patient to do the most that we can for them. And that's kind of where I gravitate to. So that's how I ended up here at the VNA.
Erika, thank you so much for sharing that. Before we get into the details of everything that hospice entails, can you tell us why you made the choice to switch from this active, busy career you had in the hospital to hospice and home care?
Absolutely. So working as an ICU nurse, we saw very sick patients come in, and at times it was too late, but you always think like, what could have prevented this? Like, how can we get to patients first? And that's really what started my journey down my nurse practitionership. Because we would have people who come in with a heart attack that waited 3 or 4 days, or we'd have people that came in, they just didn't feel right. They didn't know that this weakness on their side was a stroke. And typically they are older individuals. And, we would get the young ones, very busy ICUs, but it was hard. And it was hard to see all of the death and dying around you and thinking, what can we do to see that these patients through? How do we have people, be where they want to be when they pass? Nobody wants to be in the hospital hooked up to 17 machines, passing with your wife in the lobby because it's too traumatic or we can't get another person in the room. So it was instances like that I was like, I think I need to go to the outpatient world. And that's what started my goal for nurse practitioner. And I thought, I need to go to the outpatient side. So what better way to reach people than home health care? So I joined Ideal Home Healthcare in 2017 until I graduated with my nurse practitioner license in 2018, where I then ventured into HEMOC and internal medicine. And then I found my way back. During HEMOC, we did do phase 1 through 3 clinical trials. And of course, in internal medicine, we did a lot of inpatient, acute rehab, in-office settings. And, every time we were inpatient, I was like, you need more help in the home. So knowing the resources and the background that I had from home care really kind of accelerated my push towards helping people in the home. And I thought, I need to get back there. So lo and behold, I come back to the VNA, and here we are, starting nice little programs like palliative, transitional, and primary, but also helping with hospice. So getting to the patients that need you the most, which are hospice patients, is the most forefront prerogative of mine.
Well, your passion is evident, and it certainly speaks for itself. So what can you tell those of us who don't know? What is hospice care?
So in the technicality, hospice care is a benefit offered by Medicare and most insurance companies. So hospice is for those who have a prognosis of 6 months or less in a terminal condition. So when hospice says 6 months or less, that's what your typical prognosis would be for the average median length of lifespan left with this diagnosis, given that no treatment would be concurrent or there is no curative treatment for this. So hospice comes in and we help take care of the patient for all of the time that they have left with us. And a lot of patients end up graduating from hospice at times. The majority of our patients do thrive once on hospice because we have more resources come into the home. So for example, cancer. You have a terminal condition of cancer. You are no longer seeking curative treatments, or you are not, it's not an option for you any longer. You have a prognosis of 6 months or less. Hospice can come in and evaluate and say, here's where we see you, and here's what we can offer to help you stay in your home if that's the patient's goals of dying in their home. And we want to give you back to you the quality of life that we can with this, whatever time you have left. We want to make the improvements in your quality of life. So I think it goes into a lot of our other questions. So I'll just kind of stop there, but.
Sure, no, great. I think it's a great segue into all of the questions I have to ask. This is educational, not just for me, but for everybody listening and anybody that we can share this with. I think it's important to get the messaging out there, because why does it seem like people can be hesitant to accepting hospice care? So how does hospice care work? And maybe what are some of the stigmas that surround hospice care, and why are people so reluctant to accept something that seems like such a great service?
Right. So very good questions, because there is a significant stigma around hospice care. So it starts with, accepting that you are facing death. We have a hard time here in this country that we think that there's always going to be a cure. There's always going to be something else we can do. That could be true in some instances, but you also have to look at what are the other things that we can do. So for example, in the ICU, coming from, when someone says they want everything done, everything is very significant. You end up on cardiac bypass, you end up on machines, and the last words you get to speak to your family are not the ones that you will remember. And you're not able to talk. You're on a ventilator, you're on CRRT for kidney dialysis. So it's when there's everything to be done, there's a lot left, and it's kind of like an ethical thing. So if you have somebody that you're talking with, and it's different than the acute care setting, because we're in the outpatient world. We're talking to patients who are young, or old, but who are needing to be accepting of this diagnosis, and it's not something that we really understand at this point. So telling somebody there's nothing left we can do for you, the only option is to go home and be comfortable. Some take it and some don't. The other ones, it can be, we've tried everything we can, but it doesn't look like this is good enough. This is what we have to do. So once the patients are more of accepting of that and understanding that this is kind of real life now, I do have to do something, then that's where we can get into hospice. So hospice can come out and talk to you till you're blue in the face. You could, we could preach and tell you how great we are, but if you're not ready to accept us, we can't make you accept us. And it's not for everyone, but I truly believe it's for a lot of us. So the stigmas are that, we take you off all your medications and you die. That hospice is for only people who are dying, that as soon as I get on hospice, I'm going to be dead next week. And that's not the case. We have a lot of patients who have been on caseload for quite a bit of time. And typically, as I was saying earlier, patients thrive after we come in, because we have a home health aide, we have a nurse out there, we're managing your pain. We have physical therapy who's able to help you move around and keep your independence, or help you prevent from contractures. We have a massage therapy. We have speech therapy if needed. We can have occupational therapy to help with hand contractures. We also have mental health that we can get on board if we need, and we have bereavement coordination services. We have also spiritual care. Can't forget spiritual care and dignity therapy. And we have a phenomenal harpist. So, so we have a lot of vast options to place into patients' homes, and they kind of perk up. They do a little better. And because they're getting better care, because the majority of geriatric patients are not receiving the appropriate care in their home. I'm sure if you can think about your grandparents, loved ones, people and you think, how do they get through day to day? That's a good question, because the majority are not doing well day to day. But, it's from a time when, insurance will only pay for either skilled home care or hospice. And you have to make up the difference. And a lot of people don't choose to pay for private help to make up the difference. So when we do finally get to come in there, we're kind of being a little bit of a buffer for them for their routine activities of daily living, and they're doing better. So it's nice. And that's really where I stand with, trying to get to my patients. This isn't about death and dying. This isn't about, you're going to actively die tomorrow. You can be on caseload for years. We might have to discharge you. You might get so good, we have to kick you out. And that's, everyone likes to hear that. It doesn't happen often, but it does happen. And, So it's just a mix, but it's really getting to understand your patient, seeing what their fears are, what their stigma, what their thoughts are. I would say that for our hospice program, we have a pretty, I would use the term liberal hospice. Like, we don't make anybody take their medications off if they don't want to. A lot of times families are very perplexed and scared, if somebody's been on Coumadin for 18 years and all of a sudden we say she doesn't really need it. Well, she's always needed it. She's going to have a stroke and then she'll die from that. Okay, well, it's no big deal. We'll keep her on it. Those are trials and tribulations that we go through all the time. And it's about keeping the patient comfortable, but also keeping the family comfortable. So hearing everything and working it out to make sure that all parties are in alignment and working together and making sure that everything's perfect for all the time they have with us.
It's certainly eye-opening for me to hear that every aspect of VNAO, every part of this organization is and can be involved in hospice. And that to me is one thing that makes hospice stand out among everyone that I've talked to who is equally as passionate about their programs. So knowing that we have all of these resources and all of these options, I'm curious to know who makes up the hospice team. When you go to work every day as a hospice professional, who are those people and what do they do?
So that's a great question. So we have to look at this, and typically the driver on our hospice bus is, I'm the director, but leadership doesn't matter when it comes in your home. Your nurse is going to be your bus driver. So you have your case manager, whom we have a great mix of case managers. They are just phenomenal. And then next would be your home health aide. And a lot of times you're going to spend more time with your home health aide than you are your nurse. Typical hospice patient is going to see their home health aide 2 to 3 times a week. When you start to decline, we do increase services. 5 to 7 times, it's typically towards the end of life. We have to look at where your needs are, how many times we have people in and out of the house. Our goal is to keep, so if we have a nurse coming out 2 days a week, then we could stagger the aid so that we have somebody else in there. And if you need weekend visits, obviously we have a phenomenal triage team. Our 2 triage nurses are just amazing. So they go without question. They go and they find all our patients and just go and see them when we need it. So there's always somebody on call. And then along with our nurse, home health aide, our triage team, because they're super important too. And then next up would probably become our pastoral care and our bereavement services. So our pastoral care, spiritual care, is also linked with our dignity therapy. And of course, Courtney, you fall right into that as well. Dignity therapy, music therapy, our phenomenal harpist. So Courtney goes out to our patients and plays. I've seen phenomenal, just great, tear-jerking concerts you've put on. You've done just a phenomenal job. And so that's probably going to be our big driver. So then we have, okay, sorry, I'm getting ahead of myself, but we have our
I get to share my experience of that here in a little bit.
Yeah. So our spiritual care works with our dignity therapy, which is a program we have. And then our bereavement is kind of the caboose on everything. Bereavement can get involved early on in care if we have like a high bereavement risk assessment, which we complete on all patients, but it's to kind of judge where family members and the loved one who's going to be the bereaved is at in their grieving process, because it's going to be, everybody grieves differently. There is no right and wrong way to grieve. Some people accept bereavement, some people do not. So it's kind of feeling out where they're at, taking a true assessment of what's going on in the home. And then Thaisa's our bereavement coordinator. Thaisa's with the family for 13 months after the patient passes. So we have continuous check-in points. She also helps get us in contact with different resources, different support groups, all aspects within the community to help us with our grieving processes.
That's incredible. Can you run me through a typical visit? When a hospice team member goes in for a visit, how long are they there? What do they do? Just run me through a typical day in the life of one of our hospice care team members.
Absolutely. So I'll give you 2 examples for 2 really good ones. So So for a nurse that would come in, the first thing is, you build the rapport with the patient and the family. So you introduce yourself, you're going through checking on the patient. The patient is our number one priority, and checking on the family is our second priority. So what's going on? Has anything changed? Going through a routine system, doing a full assessment of this patient, making sure their nutrition status is okay. Have they stopped taking in as much? Are they still urinating? How are their bowel movements? Are they uncomfortable? Do they need a laxative, or do they need something for diarrhea? As far as nutrition status, do they need to start doing boost support, or protein in between meals? How much are they taking in? Like, what are we going to be expecting? Where's their weight at? How is their functional status, meaning their activities of daily living? We grade you on all 6 activities of daily living. Where are you at in still doing them by yourself, needing help, or are you bed bound? We have something called a palliative performance scale, which is assessing a patient for where they're at in their abilities. So there's bed bound, there's chair bound, there's wheelchair bound, and then there's different amounts of work. And so you get a grade on that, and then we kind of monitor. So for hospice, it is important to say that we do have to see a continuous decline. Because our services are for those who are terminal and declining. So we do have to document that. So our documentation of what we see in the visit is very, very important. We have to show that, and we report it back to CMS. We are audited. We are compliant. So we are very stringent about how we document and the way our nurses conduct their visits. So the typical average visit, I would say, is probably around 45 minutes or so. The nurses can do their documentation in the home. They can talk with the family. And of course, there's visits that are longer than that for sure. Average, I'd say that's 45 minutes is probably a short visit. So even when I'm in the home, so as a nurse practitioner with hospice, I complete all of our face-to-face assessments for individuals going into their 3rd benefit period or further. So I go in and I assess and make sure they're still appropriate for hospice in addition to our nurses. My visits typically last 45 minutes, half an hour. So I go through with the family, everything that's going on, their plan of care, reviewing where they're at, looking back at what they were prior in their previous certification period, meaning like their episode of care with us, and where they're at now. And what are we going to be doing? Where are we at? Let's think about this. How many more times, she's been pretty stagnant. Like, what are we looking for, and what are our concerns? Is she improving too much? We get patients who gain weight, who do a lot better, and then they do have to go back to home care. They have to go get therapy and start it all over again because they're too healthy for us now. So it's it's an interesting and phenomenal thing to see. But I hope I answered all the questions, but I'd say on average, you're getting 45 minutes to an hour of each visit. Your typical bath visit for a home health aide, it's about 45 minutes to an hour.
And is it the same nurses and aides visiting the patient each time?
Yes, we try very hard to keep the continuity of care. If a nurse is off, we do work with the patient, say, hey, your nurse today is off, or next week they're going to be off. Do you want us to supplement them out, or do you want to continue with your nurse? A lot of times, they're really, really liking their nurse. They're like, I don't need anything. But if we get a call and things are declining, we send our nurses out. So there's always coverage, but we do leave it up to our patients to see if they want coverage. If there's an issue going on, of course, we cover them no matter what. But the patients who can decide, we do give them that option. But the majority of the time we cover them, or they say, I'm really okay today.
So to me, this sounds like a no-brainer. When I reach that stage of my life, I hope and pray that I have a team like this to come take care of me, or my parents, or my grandparents. So my question for you is, why do some people receive hospice in the home and others go to like a facility or a place?
A hospice house.
A hospice house. Yes. What can you tell me about that?
So we actually used to have a hospice house. We did shutter its doors. I don't exactly know the year, but I do know it wasn't super long ago. But the hospice house, we have a lot of hospice agencies within the Cleveland area that are known for their hospice house. So there are different justifications and reasoning for why a patient would qualify for a hospice house. It does perceive around crisis. and needing for higher care needs to be met, and also around, actively dying. So a lot of times patients, and there is a false assumption that patients think, oh, if I go with this hospice, I'm going to go live in the hospice house. That's not exactly how it works. There has to be reason for it because it's paid for by the hospice benefit. And it's not, if you don't have the documentation and the ability to actually be there for good cause, then you do pay for it. So some patients do end up deciding that they would prefer to go into a facility, and depending on what insurance they have, their insurance either covers that facility or they pay privately, and we're able to go into the facilities and then treat them. But a lot of times patients want to be at home. They want to be comfortable. So we're specialized in a community-based hospice care, meaning we go out to patients' home-based hospice. We do have contracts with a ton of facilities around the area. If a patient is in need of higher acuity of care, we do admit them under a respite stay to facilities that we work with, and we go in and we continue to take care of them. If a patient is in need of continuous care, which means that they are in crisis and they have symptoms that need managed for 8 hours or more by nursing a day, we are able to instill that. So we can go out and we can be with patients, but it's for severe cases. It's not for, it's not for everyone. It happens for patients that are just an absolute unable to be managed on just what they have. So we have a nurse out there who then documents every hour and they manage these symptoms, and it is continuous care. So it's for the very, very, very sick.
You touched on this a little bit, but I would like to know more. How is hospice care paid for in our setting specifically?
Okay, so for our setting, it is Medicare. So Medicare is our initial biller. So we bill Medicare there, and we are paid based on a daily rate, which is how all hospices are. So we give these services, and it's based on benefit periods. So we have the first 3 benefit periods, and then after that's when we start to do face-to-face certifications by the nurse practitioner or physician that works with hospice to verify that they are continuing to qualify for hospice. With everything, there's always been a few bad apples in the bunch. So from high fraud incidences, just with home care, just like within the hospital, Medicare has high stipulations for how we monitor and grade our patients. So after the 3rd benefit period, I go out and assess all of our patients, but our billing stays the same. So we bill Medicare first. There are commercial insurances that provide hospice care. Typically with commercial or private insurances this is typically people who are younger than 55 who do not receive Medicare at this time. There is a copay, or you have to meet your out-of-pocket max. In the grand scheme, I will say that there are multiple times that we do charity cases because, when somebody's actively dying and on hospice, charging them their out-of-pocket max is not always something that the VNA has felt is appropriate to times. And I can't always say that that's been how it is for certain, but if there's cases that are, I can't afford this, I can't afford hospice, we take everything into consideration and we look at the funds that we're able to gather to assist.
It's incredible. What kind of out-of-pocket expenses can a family anticipate?
So a lot of out-of-pocket expenses. This kind of goes into like medications and equipment that's processed for hospice. So we'll kind of tether all of that up into one ball. So out-of-pocket expenses, hospice will not charge you. So we don't bill you. So we bill everything through insurance. And so for patients that come on with hospice, a lot of times they need DME or durable medical equipment, which includes like a hospital bed, an oxygen concentrator, bedside commode, wheelchair, things of that nature. Like think of like big medical things that you can't find, wheelchair ramps, things of that nature. So hospice does provide that. So not always the wheelchair ramps. That's a good example of DME though. So everyone understands what DME is. But so oxygen bed, we go through a company and they deliver it to your home. We do pick up that tab because we need to make sure that you have the appropriate supplies in your home. And as far as supplies go, typically all of the care needs supplies are ordered by us. So we provide gloves, we provide the chucks and the briefs in order to help with all of the care needs that come up. If there's wound care that we're seeing a patient for, we also cover that. But that kind of gets a little, we kind of get into an area where it's based on diagnosis. So when things are based on diagnosis, we pay for everything related to the diagnosis that you're being seen for hospice. So for example, say somebody has Alzheimer's and we are seeing them, they're going to be on for end stage Alzheimer's, but they also have a heart conditions. So people typically have Part D Medicare. So we will cover all of the medications related to their Alzheimer's disease and symptom management as far as like constipation, diarrhea, nausea, vomiting, and pain. But for heart medications like metoprolol or amlodipine, Lispro, lisinopril. So these are medications that we would bill to your other insurance, or you would continue to fill them as you typically would. That would be billed through your Medicare Part D. So we would not cover the cost of those, but your insurance will still likely provide coverage for those. So we cover everything related to the diagnosis, if that makes sense.
So with everything that encompasses, are there any supplies or equipment that hospice cannot or does not provide?
I would say typically, if there is anything that's of a gray area, we'll have a discussion with the family. There are some medications that are considered aggressive that we are unable to cover that are related to diagnoses. So there is always, I mean, I think with everything, there's some gray area, but it's always discussed. All of our patients that come on, their medication list is reviewed. We review it with our medical director and we determine what we will and will not cover. And it's a very open discussion with the patient. Hey, this medication, it's typically an aggressive curative medication. So like people who are on oral Xylota, which is an oral chemo agent, we would discontinue that because that could be sought as curative. Patients who are on aggressive management for cystic fibrosis or other pulmonary disease, we would have to have a discussion about what is considered hospice and what we will cover versus what will need to be billed through their insurance, or we'll have to find other means to cover.
It's comforting knowing that it's not everything is black and white, that there is a discussion to be had with the patient, the family, and the whole care team. So talking about the differences in diagnoses and disease and processes, what is the difference between palliative care and hospice care?
So perfect. Palliative care is for patients who do not quite meet the benefits for hospice. So like we said, that you need to have a prognosis of 6 months or less. So for palliative care, you do have to have chronic comorbidities or terminal diagnoses. Typically, we see patients who have a year prognosis or less, but are still seeking curative or aggressive management treatment. So palliative care, the perfect example, I have this wonderful little woman, and I don't know what disease she doesn't have, but she is still seeking out chemo. She's doing great. She's doing wonderful. And I told her, I said, all of your diseases really do qualify you for hospice on their own. I said, combine. I said, I can't, you have the best support system in the world. I said, your husband takes great care of you. And she's like, well, I'm just one step away. I'm like, I understand. So, she qualifies, but she still goes and she does, she has adjuvant treatment for breast cancer. So, and she also has COPD that she's doing some different treatments for that are considered aggressive. So, which is very, very wonderful. So she would qualify, but since she's still seeking aggressive treatment, she's palliative, and we stay in contact and I help manage her pain. So that's like the perfect example. Another great example is for, like, this is a good one. Like you have a young mom who's diagnosed with breast cancer and it's aggressive, but there's a chance that she's going to go through treatment. She's going to get through this. It's kind of iffy, but palliative care typically gets involved in those cases because you can always graduate palliative care. You can get better, you can go on, you can be in remission. And guess what? If it ever comes back, you'll have a palliative team waiting here for you with open arms that already knows you. So that's where palliative is. It's the bridge to, hey, you're sick, but let's keep an eye on you and let's manage you and see how we do, so that if we would ever need to cuff you into somewhere quickly, we know you and we can do it aggressively and with ease.
It's so great to know that that service is even out there and an option for people to consider. So my next question for you is, if a patient is receiving home health, why would they need hospice care?
So this is a good reason. So this is good. So hospice and home health live in separate worlds. They will always kind of be separate. So, and we have to look at this. This gets a little in the nitty gritty, but you have to look at the payer source. So for Medicare will not pay for skilled care, which is home care, and hospice at the same time. So skilled care is getting somebody who's been acutely ill, typically discharging from a hospital, skilled nursing facility, or after a surgery, getting them back to baseline or independence. And what we do in home care is we grade them. We have a plan of care and we have interventions, and we're working towards goals. And when patients start to fail those goals, we have to discharge from home care. Or if they meet the goals, we have to discharge from home care, because insurance will not pay for us to be in there any longer than appropriate, which is fine. That's absolutely, we play by the rules. So when looking at that, a patient starts to fail home care, you start to think, oh no, now what? So that's where we should start talking about palliative care. We should start talking about hospice, because, hey, Mr. Smith, we've been trying really hard. You're not really you've had 6 admissions in the last 2 months. You're not meeting goals. We're going to have to discharge you for failure to meet goals. But we need to kind of get a plan together for what happens after we leave. What are the other options? Well, if you're not ready to accept hospice, which is completely fine, let's talk about palliative care at least. It's typically just me, the nurse practitioner, coming in once a month, but we also have other resources. So say Mr. Smith has a fall or has more pain, I can refer back to home health care, or I can refer over to hospice, or I can refer to mental health. I can help get him into coordination with other resources in the community. It's one more set of eyes in the home on this patient. Versus hospice. So say Mr. Smith is declining fat and he says, yes, and I am just so tired of going to the hospital. I don't want to go anymore. Please don't make me go. You're allowed to say you don't want to go anymore. If your wishes are to stay home, stay comfortable, and just manage your symptoms here, let's do it. Let's get hospice in here and let's talk about it. So, and then we have hospice come out and we talk about what we can and cannot do in the home, where we are. You don't want to go to the hospital. One of the things with hospice is we do not like to go to the hospital all the time. Our goals are to manage you and keep you comfortable in your home. So any ER admission or any admission to the hospital has to be pre-approved by hospice, because again, we have to look at insurance and payer sources. So hospice can't pay for you to go into the hospital and have aggressive treatment. We would have to discharge you so your insurance could. So we have to have that very upfront discussion with these patients. It's very important that they realize they can't just call 911. They can, they always have the right to, but we will have to discharge them off of hospice. So understanding where they're at. A lot of patients like, no, well, if I can't do that, then I don't want this. Okay, that's absolutely fine. Let's get you on to palliative and we'll revisit this. Okay, again, okay. But some patients are like, absolutely, that's what I want. I want to stay in my bed. I just want to be comfortable. I want to sleep. We can do that. We can do that without a doubt.
Can a patient's doctor still be their doctor if they go?
Absolutely. Oh, yes. So their doctor can follow along. A lot of doctors do choose to, so they can help manage their plan of care on hospice. Or you can see our hospice medical director, Dr. Abdallah Al-Shahed. And the good thing is that you can have both doctors, and you typically do. So your doctor is going to see you. And when I say see you, that means that we call him and we talk with him or her about what's going on in your plan of care, what medications we're starting you on. And then we also run it by Dr. Abdallah Al-Shahed, because it's important that he knows, because if your doctor is not able to be contacted at 3 a.m, Dr. Shahed is. He's our guy, and that's who we would go to. So if we need something, we do have the ability to go through either physician, typically our medical director, if needed in an emergency.
Incredible. Thank you for sharing that. Um, you have said this word a couple of times, and it has me wondering, what is the difference between a diagnosis and a prognosis?
Nice. So a diagnosis is the actual disease that you are being diagnosed with. So it can also be related to different ICD-10 codes. So when you're looking at a hospital chart, you're looking for the actual, like what is the reason this person is sick? What started all of this? So typically like breast cancer or heart failure. There's different types of heart failure, congestive heart failure, right-sided, left-sided heart failure, diastolic, systolic heart failure. So there's all different nice little things, and all of our diagnoses do come with different criteria that our hospice experts are just trained in to see and map out. Yes, you meet this criteria. But the thing is that the diagnoses are what we're looking for. And then how are you doing in relation to this diagnosis? A prognosis is the average median length of lifespan left with this diagnosis or correlated with this diagnosis. So for example, when someone receives a pancreatic cancer diagnosis, the typical prognosis is 12 to 16 months. So, and that's just the average median lifespan associated with that diagnosis. So when you get diagnosed with heart failure to begin with, there's different classes and stages of heart failure. Same with COPD. So all of our diagnoses kind of have different starting points. So just because you have heart failure doesn't mean you automatically qualify for hospice. Again, we have different markers. They're called LCDs. So we have to look at that and see where you are. Heart failure in itself, though, is a terminal condition, but it is not a prognosis of 6 months or less right off the rip, if that makes sense.
Yes. Oh, yeah, complete sense. What kind of bereavement support does hospice offer?
So our bereavement support is, her name's Thaisa, and she is phenomenal. She's our bereavement care coordinator. And the way it works is that with the hospice benefit, again, we always go back to wonderful CMS Medicare. So we always look at what their stipulations are. There are things called conditions of participation. So every hospice program does have to have a minimum of what the conditions of participation say. So for example, our bereavement coordination has to be bereavement services for 13 months after death of the patient. So, but that doesn't mean that it has to start then. All of our patients also receive a bereavement risk assessment within the first 5 days of starting on services. That is part of our COPs as well. And it's to encompass that we are meeting every need of this patient. So it starts with the bereavement risk assessment. This patient their loved one is going to be at very high risk. She is as anxious as it gets. She's unable to sleep, or, we've had patients who their loved ones start, getting into bad habits, and we have to talk with them and have to get them into resources that are appropriate. We really need to talk about the caregiver. We really need to help them more. So in that case, we are able to have bereavement reach out beforehand. It's called pre-bereavement, and talk with them about their grief and how they're handling it and what they can do and how we can help them get to where they need to be.
My final question for you is, how does someone choose a hospice provider?
Okay, so when you say provider, do you mean hospice agency?
You tell me what I mean.
Okay. So every hospice agency kind of has their own philosophies, and I can't speak to all of them, but like I had said at the beginning, our hospice philosophy, I would say, is a pretty liberal take. We really look at treating the whole patient. We have a lot of support therapies that we can get involved. We work with the patient to figure out what meds that they do and do not want to stop. And of course, we try to titrate off the ones that aren't really needed, but we work with them. Some hospices make all patients across the board be a DNR, which is a do not resuscitate. We work with the patient and talk with them and give them our opinions about what type of code status they should be. It's unfavorable to have a full code in hospice, but it's not unheard of. So it's things that we have to talk about. And then we kind of make those patients kind of a red flag patient if they continue to want to be a full code. Well, let's talk about what a code would look like. Let's talk about what would happen with you in a code. Let's talk about what CPR looks like and what intubation looks like and what maybe your goals don't actually align with hospice, even though we thought they did. So it's kind of up in the air, to be honest. You know, some patients choose hospice agencies based on religious purposes. Um, you know, Holy Family is a very founded, religiously affiliated hospice in the Parma area. So a lot of patients do like to go to that if their loved ones have been there, if they know it's tried and true. I support the church and I go there and I want that to be my hospice. Absolutely. You know, that is absolutely fine. Let's work to get you there. If they're my palliative care patient, I'll set up meetings with them. If that's what you want, let's do it. You know, and then there's others, of course, like very well known ones in the area. So you just got to look and see what fits you, what would fit your needs, like what we do to set us aside from everyone else, that sets us further up, as I would say, really is our supportive services. And the approach that we take of working with the patient and the family. It's really a cohesive bond. And if you don't have that, then, you know, you need to look for another agency. But we strive to get that. And I would say, you know, 9 out of 10 times we hit it on the head. If I could say 10 out of 10, I would say it.
Is there anything else that I didn't ask or bring up that you would like to share? It could be informative, it can be educational, or it can be a story or a memory or a positive experience you've had. Is there anything else, any piece of Erika that you can share with us, with your time and experience that you've had with hospice?
Yes, you know, there is a phenomenal memory, and it was a patient. And, you know, this patient was a wonderful man, really well known in the area. And, you know, helping him to pass in a fashion that was as peaceful as he prayed it would be was the greatest gift I could have asked for. You know, I was with the family, I was there when he passed, and, you know, they called me. I was filling in, you know, I got the call from the family member and I said, you know what, I'll just come out, you know, it's a Sunday afternoon. And so I go out and I stand with the family and I'm just helping them through the symptoms and, you know, but being able to be a part of easing their anxiety and helping him to understand, you know, let's look at this. Let's see what we can do. I'm here to help you, you know, like just trust me, because I promise I won't let you down. And I'm good to my word. So it was the most beautiful experience. And of course it's sad. Of course it's heartbreaking. But as a hospice clinician, my last gift to families and to patients is peaceful passing.
Incredible. Erika, thank you so much for sharing your expertise and your passion with us today. While I'm getting the harp set up for a small presentation I'm going to be giving everyone today, I would like to give you all the opportunity to ask Erika any questions. You can unmute, you can start your video, or just type in the chat, because she is here to answer all of the questions that you might have while I get set up. If not, I invite you all to sit back and relax and enjoy my presentation on the healing power of music, while I get to share with you some of my experiences with hospice and some of the music that has been most popular, most impactful, or music that's special to those that I've had the opportunity to play for. Should also warn you, there's a baby in here. So as I'm telling my stories, if I burst into tears, I can now blame it on pregnancy, though I'm emotional anyway. And I have been told by our experts like Erika and others that it is okay for me to show that type of emotion when I am working hands-on with our patients, because it shows truly just how powerful and special the relationships are that we are building with people inside of their homes at their most vulnerable times. I'm going to start with my number one most requested piece. And ironically, when I played this for our president, Lisa Zidek, the first time, actually it was for Lisa and her mom, of all people, it also brought her to tears. So I hope you enjoy our first song of the day. And this is Pachelbel's Caine. makes music so special is that it is known as the universal language. And I think is probably the greatest reason why it's made such an impact on the patients that I've had the opportunity to play for. Whether it's classic rock, show tunes, hymns, I provide a repertoire catered specific to our patients and what it is that will help enhance their experience and their time with me. One of my favorite stories, and this happened early on in my time with VNAO, was when I took the harp into a home to visit with a patient who had advanced dementia. She was an immigrant to the United States, had been living here for about 65 years, but due to the progression of her Alzheimer's and dementia, she had forgotten all English and she didn't recognize her children anymore. So her daughter, who was taking care of her at the time, she mistook as her mother. I brought the harp into the home and played music that the family had requested and suggested based off of her beautiful life, the song she danced to at her wedding, the music that they remember singing and enjoying throughout their time together as a family, early memories of living in the United States. And after 30 minutes of playing with that family, she remembered all English. She was able to speak to me in complete sentences. She no longer needed a translator to help me understand what she was saying or to help me communicate with her. By the time we left, she recognized her daughter. And I'm getting emotional thinking about it all over again. And she asked her to send me home with bread that they had made the night before, which was her recipe that she learned from her mother, that she learned from her grandmother. And I got a phone call after my time with them, and she had remembered her family and her children for a full week after I left. And that's something that I will carry with me forever, because the music we chose, the actual physical vibration of the instrument on the hardwood floor that I had placed right next to her bed was something that she was able to feel and listen to. And one of my favorite memories of music from my time with that patient was her love for show tunes. So now I'm going to share with you one of our favorite show tunes that we played and sang in the house that day, and that is Phantom of the Opera, Music of the Night. my favorite memories during my time as a harpist for VNAO is actually a trip I took to visit one of our patients with our spiritual care coordinator. And the nurse told me that in the 7 months she had been visiting and caring for this patient, that she had never seen her get out of bed, and that she preferred to stay in her bed, in her room. That's where she was most comfortable. And they did each visit there in her bedroom. I was invited to come play for her and her family. And this patient told our nurse that she wanted to take the harp out of the bedroom. She wanted to go in the living room where there was light. And while I was setting the instrument up, she put on her best Sunday dress, which was light blue with flowers on it, another small detail that I will never forget, and that she wanted to enjoy the presentation and the harp concert in its full glory. So I sat the harp up and I asked her a few questions, and I had her repertoire and set list ready to play. And as I played this music that she has been passionate about her whole life, the nurse told me that she had to get up to get her water several times because she was singing with me at the top of her lungs, and she'd never heard her even use or exercise those vocal cords before. And she was working up a sweat because while she was sitting there upright on the couch, she was dancing as much as she could with her arms, with her legs, tapping that foot. And the nurse and I had a moment outside where we cried together because she never thought she would see the day. When we entered the home that day, the nurse asked her what her level of pain was, and she was having pain in her abdomen. And she rated that pain a 10 out of 10, that it was so severe she wasn't sure that she was up for the music that day. She wasn't sure that she could sit up or get out of bed. After I went in with the harp and she got to see it and feel it and touch it, she said, okay, let's try this and see how it goes. So we got set up, we moved into the living room, and by the time I left, I heard her ask, what is your pain now? And she said, pain? I don't feel any pain. And she said, can I help you get back into your bed? And she said, no, when my son comes over later tonight, he can help me get into bed. For now, I want to sit here and enjoy the sunshine. And if you're curious what that music was that got her singing and dancing at the top of her lungs, she is one of the greatest Beatles fans that I've ever had the opportunity to play for. Other moments that stick out to me forever are when I have the opportunity to play for husband and wife who are in our care together. And that's when they get to tell me about their story and their life together. And I get to share music that's special to them. I'm learning just as much from our patients when I get to sit and talk to them, as much as they're learning about me and this instrument. So that makes me feel even more grateful for the opportunity to get to share my gift of music with them. Next, I'm going to share with you, not only is this a highly requested piece by people when discussing their love stories, but it's also one of my favorites. I hope you enjoy Can't Help Falling in Love by Elvis Presley. The last piece I'm going to play for you today is a piece that no matter where I go, no matter who I play for, it's my number one request. I can't quite explain it. I think it's just something that people like to see. Oh, you're a harpist. You claim you can play anything. Well, do you know Stairway to Heaven? And because that is my most popular request, aside from Pachelbel's canon, it's classic rock. It's one of the most well-known, beautifully constructed songs that has ever existed. My answer is always yes. My favorite is that I know when I go into facilities that we work with regularly that this question is going to come up. And lately I've had some fresh requests for country music and a little bit of Freebird. But my favorite piece to play with you and share for you as my finale is Stairway to Heaven. Enjoy. I could certainly play for you all day and give you the history of my experience in education with the harp and teach you the ins and outs of how this incredible instrument works. And I hope to see you all again soon in person in the future. But for now, I hope that helped taught you a little bit about the healing power of music and the incredible services and opportunities that VNAO Hospice has considered and thought outside of the box to provide and offer to the patients that are in our care. If that's all for now, we will sign off. I do see we have a couple of chats here in the, oh yes, so many, such wonderful compliments. I will be sure to save all of these and share them with Erika. I cannot thank you enough for joining us today. Thank you to Erika, our incredible nurse practitioner, and thank you all for joining us. If you have any questions, you know how to find us. All of our contact information is on our website, and be sure to follow us on all social media platforms, Facebook, Twitter, Instagram, LinkedIn, for small harpy hours like this and information on the services we're providing and also some of our employee spotlights. Thanks again for joining us. See you soon.